Okay, this is part two of the August 30th lecture. I'm picking up at the History of Epidemiology section if you're taking notes in the PowerPoints. Right, so let me pull this up. Okay, so we're going to start with epidemiology in the classical antiquity period. At this point, epidemiologists, or I guess just people broadly, are using supernatural explanations to describe why disease is spreading through populations. And this is when the history of epidemiology really sort of originated. So in 400 BC, Hippocrates suggests that environmental factors, things like air, water, and food quality, were causes of disease outbreaks. So he wrote this very famous book called On Airs, Waters, and Places. And he wasn't able to delineate specific causes, but more generally, he just implicated environmental factors. And in this respect, this classical epidemiology is pretty similar to the present day. We're still often unsure of the causes of most chronic diseases. Okay, so moving forward in time a little bit, in the Middle Ages, one of the bigger incidents was the Black Death, occurring from 1346 to 1352. Around 1/3 of the population of Europe died from the plague, and it was thought to be an epidemic of bubonic plague. And untreated bubonic will go on to kill up to 60% of people who are infected. And I'm sure, as many of you know, that it's transmitted by bites from fleas. So during the Renaissance, there was Paracelsus. He was the founder of the field of toxicology. And he was the first one to sort of identify a dose-response relationship, just that the effects of poison are related to the strength of the dose. That should say dose, not does. As well as John Grant, who was the first to employ quantitative methods to understand mortality and birth data in London. He's often referred to as the Columbus of statistics. Moving on to the 1700s, there's Percival Pott. He was the first to describe there was an environmental cause of disease and suggest some sort of preventative measure. So he observed, he's been very astute, and observed that chimney sweeps were more prone to scrotal cancer as a result of their contact with the soot. And he just went on to recommend that chimney sweeps bathe once a week, and and then the rates of scrotal cancer decreased. Edward Jenner was the developer of a smallpox vaccine. His method would now be considered quite unethical, but he noticed that dairymaids who were infected with cowpox were immune to smallpox. So cowpox is another derivation, another type of smallpox, I guess. And Jenner created a vaccine using material from an active case of cowpox and gave the vaccine to an 8-year-old boy. And as a result, ended up saving millions of lives, but gave it to a boy who could have died. He didn't know how the vaccination was going to work. So at this point in time, there's really no connection between microorganisms and disease. A pretty common theory was the miasmatic theory of disease, just that disease is transmitted by a cloud. So dirty air, dirty water, or usually dirty air is transmitting disease. Ignaz Semmelweis was the first person to sort of, one of the first people to start to think that there was something more than the miasmatic theory. So childbed fever was a major cause of mortality among women in the 1800s. Mortality rates were as high as about 25%. And a popular theory was that it was some sort of epidemic constitution of the women, or putrid air or solar or magnetic influences that resulted in childbed fever. So Semmelweis was in charge of 2 obstetric clinics and noticed that the mortality was twice as high in one clinic as it was in the other. So the first clinic was staffed by medical students and doctors, and the second clinic was staffed by midwives. And he knew that physicians would begin their day by performing autopsies on the women who had died from childbed fever, and then they would go to the clinic to provide clinical care for childbirth. So they'd do the autopsies, and then they'd go perform deliveries. But midwives did not perform autopsies. So Semmelweis thought that mortality was higher in the first clinic, in the clinic with the doctors, because physicians went directly from autopsies to patient care. And he suggested that the hands of physicians were transferring disease-causing particles from the cadavers to the women about to deliver. And he wanted to get physicians to use chlorine. So what he said was, you guys should just wash your hands, get these disease-causing particles from the cadavers off. And he also wanted them to use chlorine when they wash their hands. Not because he knew that it was one of the best disinfectants we have, but because he wanted to get rid of the smell, actually. And when he required that physicians wash their hands, this is what we saw. So the red line is the first clinic, the clinic with the doctors. The green line is the clinic of the midwives, right? And this is just the maternal mortality rates due to childbed fever. And as soon as he implemented this intervention, maternal mortality rates decreased drastically in the first clinic. But people weren't very thrilled. So the doctors were upset because Semmelweis's theory made it look like they were the ones that were giving childbed fever to the women. And in fact, they were. But at this point in time, right, there's no germ theory of disease. Also, Semmelweis wasn't very tactful, so he publicly berated a lot of people who disagreed with him. And made some influential enemies. So eventually the doctors gave up the chlorine hand washing, and Semmelweis lost his job. He tried to convince doctors in other parts of Europe to wash with chlorine, but no one would really listen to him. And over the years, Semmelweis actually got even angrier and stranger, and your book kind of does a good job explaining this story. But he developed a mental condition brought on by potentially syphilis. Or Alzheimer's disease, and he ended up being committed to a mental asylum when he was around 45 years old, and actually died from sepsis. So pretty much he ends up dying from the exact same thing he was working so hard to prevent. Years later, the exact cause of childbed fever was determined to be streptococcal infection. Also in the 1800s was John Snow, and he's considered really the father of modern epidemiology. He has 2 seminal studies that we're going to walk through. But what you need to know is that in 1854, there was a huge cholera epidemic in London. So John Snow suspects that water is the source of the infection, and he was trying to look for a relationship between pumps and the cases of cholera. So he went out in the community and he just started asking people, where they got their where they lived, and then he also drew where they lived on a map, which is what you see here, right? So you see pump A, pump B, pump C, and then the dots are where people with cholera lived and worked. And what you see here is that all the cases are kind of clustered around pump A. So Snow concluded that the Broad Street pump A, was most likely the source of infection. And he actually then went back out and surveyed all these people who had cholera to see where they were receiving their water, and most were reporting the Broad Street pump. And what he did is he just took the handle off the Broad Street pump, and the cholera epidemic ended. He obviously had to get some approval from the health department to do so, because a lot of people didn't believe him. He also noted that there was no cases of cholera that occurred in a 2-block area east of the Broad Street pump. So that's these 2 blocks right here. And that was because it was the location of a brewery, and they had a deep well. So the brewery workers got their water from the well. And And of course, we're not getting cholera. The second important study is the water company study. So there was the Lambeth Company and the Southwark and Vauxhall Company. These were two water companies that serviced the areas with the highest death rates. Both companies obtained their water from the Thames. Southwark got water downstream of London, and to avoid sewage contamination, Lambeth Company got water upstream of London. And Snow suspects that the water downstream of the Thames was the source of the contamination. And this is the data from his this is mortality from cholera in London related to the water supply. And what you can see is that the water from downstream of London, this is Southwark and Vauxhall, the death rate is 4.2 per thousand population. The water from upstream of London, the death is 0.5 persons per thousand population, so 1 in every 2,000 persons is dying. So he demonstrates that there's a higher death rate from cholera in households served by Southwark. So why is John Snow important? Because he developed a testable hypothesis, and then he went out and tested his hypothesis with a rigorous study. You know, and he was sort of the first person to go around door to door and investigate disease. That's sort of he was. So with no knowledge of microorganisms, he demonstrated that water could serve as a vehicle for transmitting cholera. And that epidemiologic information could be used to prompt public health action, right? So he convinced the city to let him take the handle off the Broad Street pump. William Farr is famous for his mortality work. He used a more sophisticated method for codifying medical conditions. It's sort of the early basis for for codifying death certificates. Robert Koch verified that human disease could be caused by living organisms. So he isolated the bacteria that caused anthrax and cholera and tuberculosis. And he came up with these postulates that then became sort of a requirement for infectious disease, for causality with an infectious disease. And his postulates are that organisms must be observed in every case, that an organism must be isolated and grown in pure culture, that the pure culture must reproduce the disease when it's inoculated in an animal, and that the organism must be observed in and recovered from an animal. So one problem with Koch's postulate, and we'll talk about this more when we have our causality lecture, is that some organisms are actually very hard to grow in culture. So, and also some organisms aren't going to be observed in every case. Sometimes, you know, the disease causation isn't so specific, and also reproducing the disease in an animal, in another host, again, with bench work, things don't always work. It's not always as easy as you want it to be. But more on the postulates later in the term. So as of the 19th and 20th centuries, the mid and late 1800s finally started to focus on infectious diseases, you know, coming in, and germ theory, right? Koch was the first one to sort of really make the case that these germs were the cause of disease. So in the 19th and 20th centuries, we start to see a move away from germ theories. So you're expanding to these non-infectious diseases. The really big one in the 30s and 40s is identifying that there's a relationship between smoking and lung cancer. And also at this point, people are starting to study cardiovascular disease and understand why the rates of cardiovascular disease are increasing in the country. In the 60s and 70s, epidemiologists eradicate smallpox. And in the 80s, epidemiology starts to extend to the studies of injuries and violence. However, new infectious agents are emerging. So HIV, right, comes about in the start of the epidemic, happens in early 80s, 1981, usually considered the start. And Ebola virus, I guess, is actually identified late 70s. And in the 90s, epidemiologists start to begin to consider the spread of disease through bioterrorism. So what you see And a lot of this work is sort of two transitions. The epidemiologic transition is a shift in examining morbidity and mortality that's caused by primarily infectious agents to causes associated with chronic and degenerative diseases. The demographic transition is what happens when you sort of evolve from an agrarian society that has high birth rates and death rates to lower birth and death rates that's observed in developed countries. Right, so now moving on to disease transmission. I think this is your chapter 2 in your book. So many of the underlying principles we have in terms of disease transmission are most clearly demonstrated with the communicable disease as the model. It's so much easier to talk about disease transmission if we can talk about a microorganism, right? Which is why this part of the lecture is going to focus on ID-EPI. So the epidemiologic triangle is a long-standing model that we use to describe the etiology of infectious diseases. And its disease is just described as in the interaction between the host, a vector, an agent, and the environment. So an agent being some sort of factor like a microorganism, the host being the person who's afflicted with a disease, environment being where the disease-causing agent may exist, survive, or originate. And to have disease transmission, you have to have the interaction of all 3 or 4 of these things. So here's a depiction of the epidemiologic triangle. Your vector is going to be the organism which transmits the disease. So you could think about mosquitoes or ticks. There's not always a vector for disease transmission. Sometimes the agent will just directly infect. The host. So you can use this triangle to think about different places to intervene, right? You're trying to sort of break the link between all these pieces. So a good example here to put this into context would be malaria, right? So the host, again, up here would be a person. The agent is P. falciparum. Your vector will be the female Anopheles mosquito that transmits malaria. And the environment is watery breeding grounds. So, you could try to change the environment. You could bring in bed nets. You could try to eliminate. Sometimes you see like mosquito control interventions. And then you could also just treat the actual infection, which is also what we see a lot with malaria. So some agent characteristics that really matter. So we're starting at the bottom of the triangle here. Is infectivity. So this is just a capacity of an agent to enter and multiply in a susceptible host and produce infection or disease. And contagiousness, which is the ability of an agent to spread beyond the infected host to susceptible hosts. So infectivity and contagiousness sort of sound like they could be the same, but they're actually very distinct. They're distinctly different. So you could have some sort of agent that is highly infectious, but not highly contagious. That would be something like Ebola, right? You could be exposed to something a very small amount of Ebola virus. It's highly infective. Exposed to a small amount and still get, and it could still multiply in a person and produce infection or disease. But it's not that contagious. It doesn't go on each person that is infected with Ebola goes on average to infect 2 more people. So it has a low contagiousness rate. Whereas something like the common cold can go on and infect far more people, but you have to be exposed to much more of the virus, more virion protocols. Virulence is just the severity of the disease that's produced. And toxicity is just if there's some sort of toxic substance that's produced by an organism. The reproductive number, or the R0, is a measure of contagiousness. So generally, the larger the value of the R0, the harder it is to control an epidemic. So this is the number of cases that one case will generate on average over the course of its infectious period in an otherwise uninfected population. And if anyone watched Contagion, The movie Contagion, I think that they go over R naught at one point in the movie. So if we have an R net of less than 1, then our infection should die out. If we have an R net of greater than 1, then the infection will be able to spread in the population, because you're saying that on average, one person goes on to infect more than one person. Now there's a formula to determine your reproductive number of a disease for it's sort of beyond the scope of this class, but some factors which will affect the R naught are the duration of infectivity of an infected person, right? If you're infectious for 24 hours, you're going to probably affect fewer people than if you're infectious for 7 days. Also, the infectiousness of the organism, right? If you need to be exposed to very little virion particles or few bacteria, it's likely that the agent will have a higher reproductive number. And then the other thing that really matters is the number of susceptible people in the population, and we'll go over some herd immunity. So this is just a graph of some R naught. You can see that for Hep C, the R naught is 2. For Ebola, you have an R naught of 2. HIV, R naught of 4. SARS, R naught of 4. Mumps, R naught of 10. Measles, R naught of 18. So measles is one of the most contagious diseases, infectious agents that we know of. Okay, so host characteristics that limit the ability of an infectious agent to produce infection is immunity. And the big one here is herd immunity. So herd immunity is the resistance of an entire community to an infectious agent as a result of the level of immunity of a large proportion of individuals in the community. So with measles, we want to see 90 to 95% of the population vaccinated in order for there to be herd immunity. And the reason that herd immunity is helpful is really for the people who are immunosuppressed, right? If 90 to 95% of a community is vaccinated for measles, then children who can't get vaccinations, or some sort of immunocompromised persons with AIDS, persons going through chemotherapy, then don't have to worry about being susceptible to these agents. So in this graph, this is showing you what we see when we don't have vaccination. So this is no vaccination, no herd immunity, and you see a huge outbreak. So this is some sort of disease with an R naught of 2. So this one person goes on to infect 2 people, this top person goes on to infect 2, infect 2, infect 2, right? So without vaccinations, a disease like measles can spread rapidly, causing huge outbreaks. So all these gray circles indicate that the person was susceptible. Now, in this depiction, we see some vaccination, and the vaccination is equally distributed in the community. So you have full herd immunity, right? There's no outbreak. So this infected person goes on. So again, we have an R naught of 2. This person encounters 2 people, but the first of which, this green dot, this person has been vaccinated. So the disease can't go on to infect them. Whereas this person down here has not been vaccinated, so they are infected. But because we have so many other vaccinated persons in the population, the disease doesn't spread beyond these first 2 people. So on average, we want one infected person to cause less than 1 new case in order for us to control some sort of epidemic that's happening. Now, if vaccination is not equally distributed, but it's sort of clustered in communities, large outbreaks are possible, even when the vaccination coverage in the overall population is high. So as an example, I'm actually not sure what the measles vaccination rate is for the city, but let's say it's 90% for New York City. But we do know that there's communities within New York City that have really low vaccination rates, where we're worried about things like a measles outbreak. Park Slope is a good example of this, where there's a lot of parents who won't vaccinate for measles. And what that means is that you're a susceptible person living in that community, it's likely that if there was an outbreak, you wouldn't benefit from herd immunity, right? So there's sort of just partial herd immunity, just the people on the top don't have to worry about getting infected. A couple more host characteristics. There's something called being a carrier. So this is a person or animal that harbors an infectious agent without discernible disease. A good example of this is typhoid Mary. And we'll talk through. We'll talk about Mary, I think, later in the semester. Also, the term index case is just the first case of a disease to come to the attention of authorities. So it doesn't necessarily have to be the first person infected, but rather the first person that we know about. Environmental characteristics. This is just how the external environment will influence things that are not a part of the host. So something like environment, access to clean water, climatologic environment, just being in a warm, moist environment allows for mosquitoes, which can carry all sorts of diseases. Biologic environment is the availability of plants and animal species that can act as reservoirs for disease. Environment, something to think about is just that overcrowding, spreads disease pretty quickly. In terms of transmission of infectious agents, we have direct transmission, which is, as it sounds, it's direct and essentially immediate transfer of some sort of agent. And we have indirect transmission. So this is vehicle-borne infections, some sort of inanimate objects, or contaminated food, or something that is a vehicle for the infectious agents. Airborne infections are considered indirect, so it's the spread of droplets in the air. Dust that might contain microbes. And vector-borne infections. These are animate objects, things like insects, bats. We also have clinical and subclinical disease when it comes to infectious agents. So clinical disease is what's readily apparent. Subclinical disease is not readily apparent. I think HIV/AIDS is a pretty good example here, right? AIDS is clinically apparent. HIV can be subclinical for years and years and years. People are infected and they don't have any illness until their CD4 counts get low enough. So clinical disease is characterized by signs and symptoms, again, and subclinical is inapparent. So you have preclinical, where you're not yet clinically apparent, but you're sort of destined to progress to clinical disease, and subclinical. And when you're subclinical, it's not clinically apparent and it's not destined to become clinically apparent. And all these infections without some sort of clinical illness are important. And it's because you need to understand them for disease prevention and to understand transmission. And because it's not sufficient to count only the cases we can see if we're trying to control some sort of outbreak. Examples of this would be something like polio. So pre-polio vaccination, most cases were actually subclinical, but still capable of spreading disease, right? So if you want to control the polio epidemic, if you want to stop polio, you need to know about the cases that are subclinical. The epidemiology of polio cannot be explained without recognizing and assessing your pool of subclinical cases. Same as tuberculosis. Tuberculosis is often subclinical and unapparent. All right, so moving on to disease outbreaks. This figure here is showing you a couple different types of epidemic curves. So in the top left, we have a common intermittent, exposure source. And what that means, and as this is sort of in opposition to figure 2, which is common continuous. And in common continuous, you just see that people are being continuously exposed to something, and there's lots of cases now, whereas in figure 1, that was figure 2, and in figure 1, it's intermittent because you see there's these days where we don't have cases. So you would expect that during those days, where people are not being exposed. So a common source outbreak is one in which people are can be exposed either intermittently, as in figure 1, or continuously, as in figure 2, to some sort of common harmful source. So figure 3 is what we call a point source epidemic curve, and this is like actually what's pretty. It's pretty. This is the typical epidemic curve that you'll see, right, where you have one case who goes on to maybe a few days later. You see then after this person is infected, other cases showing up. So this one person infects one more person, infects one more person, but it takes a couple days. And with a point source outbreak, there's usually some sort of common source, but the exposure period is pretty brief, right? All the cases occur within one incubation period. So you have this one person that was exposed to something briefly, and then there's sort of a drop because this person hasn't. The incubation period is maybe in this case it looks like it's 1, 2, 3, 4, 5, 6 days. Figure 4 is showing you an example of a propagated epidemic curve. A propagated epidemic is when it's spread from, again, spread from person to person, as in a point source epidemic, but you'll see multiple waves of infection. So someone that was infected in the first wave can be later reinfected, which is why you see the curves getting bigger, because people up here are actually getting reinfected later on. So people at from days 1 to 30 are then later infected in days, say, 60. And this can be really common with a lot of foodborne outbreaks, right? So something like norovirus, where you could get infected, go home, infect your family, and then your family could reinfect you. Right, so really quickly, I'm going to show you a very stereotypical point source epidemic from a SARS outbreak that occurred a few years ago. SARS is severe acute respiratory syndrome. It's a viral illness. It's the SARS-associated coronavirus. Some of the symptoms that people get are very high fever, headache, body aches. After 2 to 7-ish days, people will begin to develop respiratory symptoms, and most go on to develop pneumonia. Spread is from person to person. It's via droplets, so coughing and sneezing, or also sometimes touching surfaces that are contaminated with droplets and then touching eyes, nose. In 2003, there was a pretty large outbreak. There was around 8,000 cases, of which 800 persons died, 10% death rate. In the Amoy apartment complex in Hong Kong was the center of the outbreak. There was a break in plumbing, and fecal waste was becoming aerosolized, which is how they think the Amoy apartment complex outbreaks started. So there was 329 infected and 42 deaths. So the health department, the CDC, the WHO were involved in this outbreak investigation, and they came in and along with like Hong Kong health authorities, and imposed a 10-day isolation because so many people in the apartment complex were affected. So they moved people to a confinement camp, but 147 people fled to relatives or hotels and continued to sort of propagate the epidemic. But this is the epidemic curve from the Amoy complex, and it's a perfect point source epidemic. So you have one case on the 14th of March, and then 7 days later, right, you see the rest of the cases that are starting to occur. So, and what these graphs can sometimes tell you about is the incubation period of some sort of infectious agent. So this is the interval from receipt of infection to the time of clinical illness. So a good example of this is the plague. So when people were frightened of the plague, the Venetian Republic began to detain people who were entering shipping ports for 40 days to see if any sort of infection developed. And if it did not, then they'd say, okay, you guys can come in and um, uh, you guys can now enter the city. And Black Death was kind of the origination of quarantine for disease. So isolation and quarantine, right, are only useful if you can catch someone during infectious periods. In the US, CDC is responsible for quarantine. CDC is responsible for preventing the introduction, transmission, and spread of communicable diseases from foreign countries into the United States and within the territories. CDC actually issues very few federal isolation orders. I just said CDC was responsible for quarantine, which is true, but they're responsible at the federal level. In fact, most states are responsible for issuing quarantine orders. And when CDC issues federal isolation orders, it's usually for persons with infectious tuberculosis. Otherwise, quarantine is left up to states. But in the event of conflict between the feds and the state health authorities, the federal law is supreme. So CDC gets to quarantine really who they want, although they do not. Again, it's uncommon to issue an isolation order. Isolation separates sick people from healthy people. Quarantine separates and restricts the movement of people who are exposed to a contagion to see if they become sick, right? So if you're isolated, it means you're already sick. If you're quarantined, it means we're seeing if you're going to develop disease. So there's only a handful of conditions for which apprehension, detention, or conditional release of persons are authorized and must be specified by executive order. These include things like cholera, diphtheria, infectious tuberculosis, plague, smallpox, all the hemorrhagic fevers. So these are your Ebolas, Lassa, Marburg, as well as SARS and any sort of influenza from a novel or reemergent source. So if we thought the 1918 flu was coming back, or if avian flu was becoming a problem. Quarantine actually began in the States. Quarantine law began here in New York to control a smallpox outbreak. And quarantine is interesting because if you guys want to read up on the history of quarantine, it's actually pretty interesting, and it raises a lot of like civil rights issues, particularly when there's instances of long segregation. Actually, we're talking about Typhoid Mary today. So Mary Malone, commonly known as Typhoid Mary, was the first asymptomatic carrier of the pathogen associated with typhoid fever. So she infected at least 51 people. At least 3 of them died, and she was twice forcibly isolated. So she was the first person we ever knew about she was the first person that made us realize that you could be a carrier. You could be asymptomatic and transmit disease. And what she was doing was working as a cook in New York City for families. And of course, family members kept becoming ill in these houses in which she served. And as soon as they became ill, Mary would leave and find a new family to work for, which is part of the reason they quarantined her, because they thought that, maybe because she kept leaving when people became ill, it made them think that she realized she was doing this. One of the families actually ended up hiring a typhoid researcher. He noted that 3 weeks before the family had typhoid, the family had hired Mary to cook for them. He also noted that she left the house shortly after the outbreak occurred, and he sort of suspected that Mary was the reason for the outbreak, although he didn't totally understand how she could be. But he does go around and ask all the other families, a lot of other families, if they knew Mary. So Mary admitted to having poor hygiene, but never in her entire life actually believed that she was a carrier of typhoid. She was held in isolation at a clinic on North Brother Island, so north of Manhattan, for 3 years, and then ended up being released. So this is the first time she's isolated. She was released, and she goes and works for a hospital, and they told her, under no circumstances are you to work with food, and she starts working with food, and then there's a huge outbreak at the hospital. And then she's forcibly isolated for the second time. And the second time, they actually just put her in isolation for the rest of her life. And she kind of became sort of a minor celebrity. Every year, someone would interview her, and she still would just, she never, ever, ever believed that she was going on to infect people. So you can actually look up some of these old interviews with her if anyone's so inclined or interested. All right, so that's bringing us to the end of the PowerPoint for your first lecture. Generally, we'd end this class with a reading, but since I'm not there, it's a little hard to do. So for next week, we're going to be going over chapters 3 and 4 in the book. We're also going to be talking about STD, the epidemiology of STDs. So there's 2 articles you need to read. One is Patterns of Gonorrhea and Chlamydia Positivity in New York High Schools. The other is Seroprevalence of Herpes and Characteristics Associated with Undiagnosed Infections in New York City. If you can't do all the readings before we get to class, I'd say to prioritize the articles because those are what we'll be discussing, whereas I'll go through, whereas the lecture will be on chapters 3 and 4. Right, and I will see you guys at the beginning of September.